Hello, I'm Dr. Russell Barkley. I'm a clinical professor of psychiatry at the Medical University of South Carolina in Charleston. Welcome to this internet course on ADHD in adults. This is part 3 of a 3-part program dealing with adult ADHD. This part will discuss guidelines for assessment of ADHD in adults, as well as treatment strategies for management of the adult stage of the disorder. Part 1 dealt with the diagnosis of ADHD and its underlying nature. Part 2 dealt with impairments likely to be associated with the disorder. As I've said, this part will deal with the assessment and management of ADHD in adults. Before we begin, let me disclose to you my sources of support during the previous year so that you can evaluate whether there is any potential conflict of interest with the contents of this course. I'm retired from the University of Massachusetts Medical School, for which I receive a pension, but obviously I'm not retired from clinical practice. I've spoken for a number of hospitals, professional associations, and healthcare organizations during the previous year. You see a list of these here on the slide. I have been paid for these presentations. I also have a number of products related to ADHD in the marketplace, including books, videos, a newsletter, and internet continuing education courses such as this one, for which I receive royalties. Finally, I have worked as a speaker for and consultant to a number of pharmaceutical companies with ADHD medications in the marketplace, and I have been paid for these presentations and consultations. I also worked as a paid expert witness for the Eli Lilly Company for several patent disputes during the previous year. This course is about ADHD in adults, and this part in particular is about the assessment and management of the disorder in adulthood. For more on these topics, please see the sources below. In addition, I encourage you to take Part 1 and Part 2 of this course before proceeding to this particular part on adults with ADHD. There are a number of guidelines for conducting the evaluation of an adult with ADHD. Let me list a few of these guidelines that I consider to be essential. First, the assessment relies on the self-reports of the individual with regard to their ADHD symptoms. But as discussed in my other program on diagnosis and subtyping on this website, when considering the evaluation of an adult with ADHD, one needs to use modified DSM criteria with regard to their current symptoms. For instance, DSM-4 criteria were developed on children and for children, and were not phrased for use with adults, nor were these criteria tested on adults, and so it was unclear whether the diagnostic thresholds used in the DSM-4 criteria, such as 6 symptoms on either symptom list, are appropriate for detecting adult ADHD. As I have discussed earlier in Part 1 of this course on adult ADHD, a threshold of 4 symptoms would be better at detecting the adult stage of the disorder than 6 symptoms. And so when evaluating an adult with ADHD, look for the individual having at least 4 symptoms of inattention, each of which occurs often or more frequently, or having at least 4 symptoms of impulsiveness and possibly hyperactivity, again with each symptom occurring at least often or more frequently. This threshold represents approximately the 93rd to 95th percentile for the adult population, as determined by various studies of ADHD symptoms in general population samples. This is why it is recommended that you use a threshold of 4 symptoms, rather than 6, when evaluating whether or not the patient's current symptoms meet diagnostic criteria for the disorder. Review again the DSM-4 symptoms with the adult, but now with regard to their recall of their childhood symptoms. In this case, research indicates that the threshold of 6 symptoms on either symptom list can be used as an appropriate threshold with regard to the retrospective recall of childhood functioning. So to reiterate, when considering current symptoms, use 4 out of 9 symptoms on either list. When considering the recall of childhood symptoms of ADHD, use the recommended DSM threshold of 6 symptoms from either list. Now, besides looking for these symptoms through a structured interview, I strongly recommend that you interview someone else who knows the patient well. As indicated in other courses on this website, adults with ADHD are likely to underreport their symptoms, and especially their impairments, at least up until 27 to 30 years of age. After this time, their symptom reports begin to converge on the reports of other individuals. Correlations have been found between self-reports and other reports, averaging about 0.74 for these symptom reports when adults are at least 30 years of age or older. Below 30 years of age, correlations appear to be down around the level of 0.4 or worse. For these reasons, it is strongly recommended that a collateral, friend, parent, spouse, or someone else who knows the patient well be interviewed about the patient's symptoms and also their impairments. In addition to these interviews, I strongly recommend that you obtain the archival records for the individual's educational functioning, and if necessary, obtain their driving record and their criminal record as well. These records can provide external validation for impairment in these domains of major life activities to help corroborate the self-reports of impairment. I also recommend that you use a symptom onset criterion of ages 13 to 16 rather than age 7 recommended in the DSM. Age 7 is more appropriate to children. Even then, there is very little scientific evidence for the validity of that age of onset. DSM-5 is likely to consider adjusting this criterion to an onset of at least 12 to 13 years of age, and my own research indicates that 16 years of age would actually be a better age of onset, but at least ensure that the symptoms have developed sometime in childhood or adolescence, and at least before ages 12 to 16. Also, ensure in evaluating the patient that the symptoms have had a chronic course, with no periods of symptom remission. ADHD is a relatively chronic disorder over time, and although hyperactive symptoms do decline with age, difficulties with inattention, distractibility, problems with persistence, working memory, and other disorders or deficits in self-regulation and executive functioning are likely to be chronic in nature. Now, the impairments that may arise from these symptoms may undergo some remission from time to time, depending upon the kinds of accommodations that are being made for the symptoms in various environments. So while impairments may not necessarily be chronic, symptoms should show a chronic course. Now, one also wants to establish that impairment is present in at least one or more major life activities. And as I discussed in part 1 of this course, impairment means significant deficiencies relative to the norm or average person in the population, not relative to the individual's IQ, particularly if they have high levels of intelligence, and certainly not relative to some specialized peer group in which the individual happens to be functioning at that time, such as other graduate students, other students in medical school, or individuals working in a profession for which an extensive amount of education was necessary, such as working in a law firm or in a hospital as a physician. In other words, we want to determine that the individual is impaired relative to the average person in the population. That is the standard required under the Americans with Disabilities Act, and I also believe it should be the standard that clinicians should be using in determining the presence of impairment during clinical evaluations. If the impairment has developed much later than the onset of symptoms, then the clinician needs to explore the possible reasons why this might be the case. For instance, individuals with ADHD who are relatively high in intelligence may find that their symptoms developed quite early in life, but they did not become impaired in educational settings until late elementary school, middle school, or even high school. So that IQ has been shown to delay the onset of impairment in educational settings, but it does not delay the onset of impairment in non-educational settings, such as in family functioning, social relationships, driving, management of money, and so forth. So consequently, while there may be a delay in the onset of impairment in a particular domain, clinicians are likely to see impairment existing in other domains that are not necessarily related to one's level of intelligence. This would be an explanation that could be provided in the report as to why onset of impairment in a particular domain may have been delayed. I strongly encourage you to use rating scales of ADHD symptoms that have been well standardized for use in an adult population in order to establish the degree of developmental inappropriateness or deviance of these symptoms. Developmental inappropriateness is a requirement in the DSM criteria for granting the diagnosis of ADHD. Because symptom thresholds in the DSM-4 were developed on children, they do not provide a good index of developmental inappropriateness for adults. As I've already indicated, a symptom threshold of 4 is a more appropriate index of an individual placing at about 1.5 standard deviations above the mean, or at about the 93rd to 95th percentile. But rather than guesstimate these thresholds as an index of symptom inappropriateness, I would strongly recommend that you use rating scales as a measure of developmental inappropriateness instead. There are a number of such rating scales on the market. For instance, I have an adult ADHD rating scale that has been normed on a representative sample of the U.S. population. There is also the Conners Adult ADHD rating scales. Certainly there is the World Health Organization screener that appears to be available on the Internet. And finally, Tom Brown has the Brown ADD scales that might also be useful for this purpose. One of the advantages of my own rating scale, by the way, is that it is the only scale that contains symptoms of the second or other attention disorder known as sluggish cognitive tempo and described in Part 1 of this 3-part course on adult ADHD. So you might find my scale useful in detecting this type of attention disorder as distinguished from ADHD. Another purpose of the evaluation is to rule out other disorders that may provide explanations for the individual's inattention or for their impairments. Remember that inattention is a characteristic of many psychiatric and learning disorders and is not exclusive to ADHD alone. Panic attacks, anxiety disorders, major depression, bipolar disorder, and other disorders are known to interfere with attention from time to time. So that inattentiveness is a nonspecific symptom of psychopathology and not necessarily an index specifically of adult ADHD. So one needs to determine that the patient's inattentiveness is not due to some other psychiatric or medical disorder, such as a sleep disorder or middle ear infections, and so on. Also, one needs to determine whether the complaints of impairment in specific domains might not be better accounted for by other cognitive, learning, or psychiatric disorders. For instance, it is possible for an individual to be doing poorly in a college environment because of low intelligence or a specific learning disability. For these reasons, an individual needs to be given a brief screening inventory for their level of intelligence, such as the Wechsler Brief Intelligence Test or Kaufman Brief Intelligence Test. They also need to be given a screening battery for reading, math, and spelling to determine the possibility that a specific learning disability might better account for the difficulties in the educational environment. In this case, one could use the Wechsler individual achievement tests, the wide range achievement test, the Peabody Individual Achievement Test, or subtests of the Woodcock-Johnson in order to quickly screen for learning problems. Should the individuals fail the IQ screen or achievement screen, they could be brought back in for more thorough neuropsychological testing to evaluate for these problems. Also, keep in mind that anxiety and depression and other disorders are associated with inattention and can also produce impairments in educational and occupational environments. Therefore, I recommend that you rule in or out the possibility of these other comorbid disorders using such rating scales as the Symptom Checklist 90, revised form, that is SCL90R, or the MMPI-2. Anxiety disorders are known to occur in 25 to 35% of adults with ADHD at a minimum. Also, depression may occur in at least 20 to 30% of adults with ADHD. So sometimes it is not necessarily the case that one is ruling these in or out as explanations or alternatives to adult ADHD, but when one may be attempting to determine whether or not they are a second coexisting disorder with adult ADHD. One also needs to evaluate for the possibility of malingering. I will have more to say about how one might go about doing so, but keep in mind that if there is an immediate positive benefit to be received from the diagnosis, the likelihood of malingering is elevated, and clinicians need to take steps to rule in or rule out this possibility in their adult ADHD referrals. Now, one question that often comes up in the evaluation of an adult for ADHD is whether or not neuropsychological testing is of some usefulness or some validity in determining the presence of this disorder. The answer, unfortunately, is no. There are no neuropsychological tests that are sufficiently accurate at detecting adult ADHD that I could recommend them for use in clinical practice. Studies have shown that various tests, such as continuous performance tests, executive function tests, working memory tests, and so on, do not have adequate positive or negative predictive power to detect the disorder, and therefore to recommend their use in clinical practice. Positive predictive power refers to the likelihood that the individual will have ADHD if they are found to have an abnormal score on one of these tests presumed to measure the disorder. Similarly, negative predictive power refers to the likelihood that a normal score is an index of normal functioning, that is, can be used to rule the disorder out. Oftentimes, test publishers, or those arguing for the use of neuropsychological tests in evaluating ADHD, present evidence for sensitivity and specificity, but these are the wrong statistics. Sensitivity and specificity are indexes of whether or not an individual who has the disorder or doesn't have the disorder does or does not perform poorly on these tests, but that is the opposite sequence in which test scores are being used in clinical practice. In clinical practice, one has the test score already and wishes to know whether or not it indicates the presence or absence of the disorder. For making that determination, the statistics of positive and negative predictive power are more appropriate than are statistics for sensitivity or specificity. Please keep this in mind when claims are made that a particular test might be useful for the diagnosis of adult ADHD. Typically, what we find in research studies on neuropsychological tests is that abnormal scores may well indicate that some disorder is present, often with a power of at least 80 to 90%. Now that may seem very impressive to you, but it isn't to me, because in general, the predictive power of these tests for adult ADHD is down around only 60 to 70%. What the data are showing is that some disorder might be present if the test is failed, but the test cannot tell you what disorder is producing the failure on the test. It could be any number of disorders that interfere with performance on these tests. More telling, however, is the problem with negative predictive power. As I said already, negative predictive power refers to the likelihood that the individual does not have the disorder, given that they have passed or obtained a normal score on these tests. Here what we find is that the false negative rate with these tests is too high. Many adults with ADHD can pass these tests. Indeed, 35 to 65% of adults with ADHD have been found to get normal scores on these tests while otherwise having a legitimate case of ADHD. So, normal scores cannot be used to rule out the disorder. So even if abnormal scores mean that some disorder is present, it doesn't necessarily indicate that disorder is ADHD. A structured interview of psychiatric disorders would have to be used to determine what disorder is present. Likewise, normal scores cannot be used to rule out the disorder because many people with the disorder can pass these tests. For these reasons, I and other individuals who have studied this issue do not recommend the use of neuropsychological testing for the diagnosis of ADHD, even though such tests may have value for other purposes. Now, if test batteries are given, the available research suggests that the most common deficits are likely to be found on continuous performance tests. The second most common performance problems are likely to occur on measures of working memory, particularly nonverbal working memory, which is known to be more severely affected than is verbal working memory by ADHD. Findings of deficits on these tests would be consistent with the diagnosis of ADHD, but it would not be proof of ADHD, as I've already indicated, given the findings for positive and negative predictive power. So if one wants to do testing, and one finds that these test scores are impaired, they might lend some confidence to the diagnosis, but would not in and of themselves indicate the presence of the disorder. Now, just for your information, the most common findings for adults with ADHD on continuous performance tests is much greater reaction time variability, which is to say RT standard deviation scores are more of an index, reliable index of adult ADHD than are other measures. Also, commission errors on a continuous performance test are more likely to be problematic for adults with ADHD. And as I've already said, difficulties with performance of nonverbal working memory tests may also be an index of adult ADHD. But here again, such test scores do not prove that the disorder is there. And more importantly, normal performances on these tests do not rule out the possibility that the patient has ADHD. Also, for your information, research has shown that tests that measure the executive functions of set shifting, such as the Wisconsin card sort test, are extraordinarily poor at detecting adult ADHD. Also, tests of planning and problem solving, such as the Tower of Hanoi or Tower of London tests, are also especially poor at detecting adult ADHD and are the least likely to be impaired in research studies on the issue. Keep in mind that at least half or more of adults with ADHD are likely to be able to pass the various tests of executive functioning often used in neuropsychological evaluations. For more evidence of this, please take Part 1 of this course on the nature of adult ADHD, where I review several studies that have compared performances on executive function tests to executive function rating scales, showing the striking disparities in the results of these studies when these different methods are employed. Those studies indicate that rating scales of executive functioning are much more likely to detect deficits in executive functioning and daily life activities than are executive function tests. Recall from Part 1, if you've already taken that part, that we found that between 90 and 98% of adults with ADHD fell in the impaired range on these rating scales of executive functioning deficits. In contrast, fewer than 25% of these same adults fell in the impaired range on the executive function test batteries. These studies also indicated that rating scales of executive functioning were far more predictive of impairments in major life activities, such as in occupational functioning and in past educational history, than were measures of executive functioning tests. So therefore, I would suggest that you use rating scales of executive functioning rather than executive functioning tests, or at least to supplement executive function test batteries as a broader index of whether or not EF deficits exist in the patient. And here again, where normal scores on the tests are obtained, they should be discarded as uninterpretable, because they do not necessarily mean that the individual does not have executive function deficits. Now, as I've already indicated, neuropsychological testing may be needed to rule out cognitive subnormalities such as low intelligence, or to rule in or out the presence of specific learning disabilities. In this case, brief screening tests such as brief IQ tests and brief academic achievement tests would be the sort of neuropsychological testing I am referring to here. One would want to determine whether or not these factors are contributing to poor educational or work performance, either instead of, or even in addition to, the possibility that adult ADHD may be present. Testing may also be necessary in order to rule out the possibility that malingering could better explain the test results, or could better explain the patient's reports during the interviews. There are various symptom validity tests available, and research shows that they can be useful in helping to detect malingering in neuropsychological evaluations. But understand that even these tests are not foolproof. For instance, most symptom validity tests use measures of memory or of reading. As a consequence, they may not be especially useful in determining feigning of adult ADHD, even if they are useful in determining malingering during memory evaluations or academic achievement evaluations for disorders of memory or for specific learning disabilities. So bear in mind that there is no foolproof objective measure of malingering that might be useful in assessing adults with ADHD, although some researchers have found that when individuals are attempting to malinger during an evaluation for ADHD, they also appear to do poorly on these symptom validity measures. But that does not necessarily mean that individuals who dwell on these tests are not malingering. I'll have more to say about malingering shortly. Now, where the history indicates that the individual might have potential deficits or probable deficits in other developmental domains, such as in language development, motor coordination and performance, memory problems, or in spatial mechanical reasoning ability, then an individual might want to recommend neuropsychological testing to rule in or out possible deficits in these developmental domains, and to determine whether or not they might be comorbid cognitive impairments with ADHD. So neuropsychological testing might be useful for this purpose, but here again, such tests are not being used to diagnose ADHD, but are being used to determine whether or not another cognitive impairment might be present. For instance, in individuals with traumatic brain injuries, or penetrating head wounds, or individuals who have experienced various infectious diseases that may be affecting central nervous system functioning, would all be instances in which some neuropsychological testing of various cognitive domains might be indicated to see whether impairments exist as a consequence of these etiologies, regardless of whether or not ADHD might be present. But here again, those tests are not being used to diagnose ADHD per se. So I am not saying that neuropsychological testing is not useful. I am saying it is not useful for diagnosing ADHD in these patients. There is no test for diagnosing ADHD at the moment, but testing may serve other valuable purposes in the evaluation of adults, including adults who may be presenting for an evaluation of ADHD as well. With these guidelines in mind, let me review for you what I believe the recommended assessment methods are for evaluating an adult for ADHD. First, as I've indicated, the use of unstructured interviews with the patient and with a collateral who knows them well is essential in order to determine the extent of symptoms and impairments. This is especially true for individuals under 27 to 30 years of age, but I would recommend it for any age of adult presenting to a clinic for adult ADHD. One would then move to the use of structured interviews of DSM criteria for ADHD, as well as for other disorders that may be indicated as possibly being present from the interviews with the patient and the collateral just discussed. One would then use a narrowband rating scale of adult ADHD symptoms obtained from the patient as well as from collaterals. These rating scales would be completed for current functioning and repeated a second time for recall of childhood functioning. Such a rating scale is my own Adult ADHD Rating Scale 4, the Connors Adult ADHD Rating Scales, and even the Brown ADD scales. In addition to those scales, I would also recommend that you employ a broadband rating scale of psychopathology to detect the possibility that other disorders may be present, such as depression, anxiety, and so forth. In our clinic, we have used the Symptom Checklist 90 Revised for this purpose. In addition, one needs to obtain archival records supporting claims of domains of impairment that may have been mentioned in the structured interview mentioned above. Such records would be educational records, medical records, driving records, criminal records, past records dealing with previous history of services from a mental health provider or services for mental health treatments, and so on. Besides these archival records, one may also use self and other ratings of psychosocial impairment, such as the recent Barkley Functional Impairment Scale. The BFIS is the only rating scale of which I am aware that obtains ratings from self and others with regard to 15 different domains of major life activities, and that is normed on a U.S. population from ages 18 to 92. So I recommend that you might consider obtaining this rating scale as additional evidence of impairment. Besides rating scales, as I've mentioned, the use of a very brief IQ screening test would be useful to rule in or out the possibility of a broad cognitive delay as potentially contributing to the patient's difficulties in performing in educational or work environments. These tests take only about 15 to 20 minutes to administer. I also suggested you might wish to use a brief academic achievement test to rule in or out the possibility that specific learning disabilities may be present. But again, I would suggest that these tests for IQ and academic achievement be given only where there is some suggestion in the interview or the patient's history that these problems are likely to be present. Neuropsychological testing might be indicated if the interview above suggests that the patient has experienced cognitive impairments in one or more developmental domains, again, such as language, visual spatial skills, memory, motor performance, and so on. But again, this would only be done if there was suggestive evidence in the interview that such deficits are likely to be present in view of the patient's history. Otherwise, they should not be done as a routine matter, of course, because they inflate the cost of the evaluation unnecessarily. I also recommended that you might consider employing symptom validity tests where malingering may be a possibility. For instance, if the patient is being evaluated for possible accommodations in an educational setting under the Americans with Disabilities Act, or where an insurance claim has been made, or where a financial settlement is at stake, or where criminal sentencing might be adjusted as a result of the findings of this evaluation. I do not recommend that symptom validity tests be given as a routine matter, of course, in clinical practice, where malingering is not likely to be the case. Now, there are various issues that come up in diagnosing adult ADHD. Let me review a few of these with you. One issue is the possibility that patients may underreport their symptoms. Research indicates that this is most likely to occur in individuals under 27 to 30 years of age, and the younger they are, the more likely this is to be a possibility. Consider, for instance, that the correlation between what a teenager says about their ADHD symptoms and what their parents say is only about 0.21, In other words, there is very little agreement between these individuals. By age 21, my own research indicates that the matter has not improved all that much. Our study suggested that at this age, the correlation between self-reports and other reports was only about 0.42. And it was only after about 27 years of age when correlations between patient and collateral reports began to approach that seen in older adults, which is a correlation of around 0.74. So for these reasons, one may find underreporting of symptoms and even underreporting of impairments in relatively young adults. On the other hand, there may also be the case of over-reporting of symptoms or of impairments. Here again, this may be an issue where malingering is likely and where various benefits are likely to be derived from receiving the diagnosis. Another issue that comes up is poor retrospective recall of childhood functioning. This is more likely to be the case the older the individual is, particularly if the patient is in their 50s and 60s. Nevertheless, we have found in our research, and in norming my own rating scale on adult ADHD, that patients' reports of childhood functioning is reasonably accurate and valid to be used for purposes of diagnosis of adult ADHD. This does not mean that poor retrospective recall may not plague certain individuals. It certainly can. But it is to say that interviewing patients about their behavior when they were between 5 and 12 years of age is a reasonable approach to determining whether symptoms might be present. But here again, I also recommend that you do the same with someone who knows the patient well in order to corroborate their reports of their childhood. In this case, parent reports could be used with regard to the parent's recall of this individual's childhood symptoms. Now this raises the possibility that the parents may also underreport the symptoms of the individual, or so may other collaterals. We have sometimes found that parents feel relatively guilty that their adult children are not functioning well and are being evaluated for adult ADHD. They therefore sometimes bias their reports in a positive direction in order to discourage the likelihood that the individual will receive a diagnosis. This doesn't happen very often, but from time to time we have noted that parents appear to be grossly underreporting symptoms relative to self-reports by patients, relative to reports by friends and partners or spouses, relative to academic archival records, and so on. And so this is a possibility to bear in mind when one obtains collateral reports from parents. Another problem arises in diagnosis when there is no one else available to corroborate the patient's reports of their current functioning or their history. In this case, we strongly recommend that you obtain what we call the paper trail of impairment, which is archival records of school functioning, such as past records of report cards or past transcripts from high school and college. One can also obtain driving records. As you know, ADHD often interferes with driving, and adults with ADHD are likely to have significantly more speeding tickets, parking tickets, and other traffic citations on their driving records than are normal adults. One might also obtain the official criminal record for the individual if it appears that antisocial behavior was likely to occur in the history of this patient. As I reported in Part 1 of this course on adult ADHD, adults with ADHD are highly likely to experience antisocial behavior and have a high probability of having been arrested, and in some instances of even having served jail time. So criminal records might be another paper trail of impairment that could help support the patient's claims of adult ADHD and of impairment in major life activities. But what if there are no such records available? Then individuals, or clinicians in this case, have to use other sources, as already discussed above, in order to try and corroborate the patient's self-reports. Another problem that arises in the diagnosis of adult ADHD is when clinicians view all indications of inattention as an index that adult ADHD is present. As I've already indicated, inattention is a non-specific symptom. It is virtually universal across most psychiatric disorders, and therefore complaints of inattention do not automatically indicate that a patient has ADHD. This is especially so if the inattention is of relatively recent onset in adulthood. As I've already discussed, ADHD symptoms arise relatively early, often during childhood, and certainly before ages 12 to 16, and therefore any symptoms that have arisen after this age should be viewed with suspicion as indicating ADHD, and may well be the consequence of other psychiatric disorders that have later onset, such as anxiety disorders, depression, or bipolar disorder. Another issue that arises in diagnosis is the desire of the patient to receive a diagnosis of ADHD for various legal purposes. Most often, this is in order for the patient to receive accommodations under the Americans with Disabilities Act, either in college or in the workplace. It is under these circumstances that individuals should be evaluated for potential malingering. Research indicates that upwards of 1 in 4 to 1 in 5 adults requesting evaluations for ADA accommodations in college, claiming to have ADHD, are malingering. And so while the vast majority of patients are not feigning symptoms, it's possible that at a minimum 1 in 5 such patients is doing so. So keep in mind, when legal issues are at stake, the possibility of malingering increases, and it needs to be ruled out using various approaches that I've already discussed. Now, how is adult ADHD different from other outpatient disorders in ways that might be useful for differential diagnosis? Keep in mind that ADHD symptoms are often quite severe, that they are chronic and unremitting, as opposed to symptoms of other disorders that may be episodic or periodic. They produce significant impairments, often serious or severe impairments, particularly in educational functioning, occupational functioning, social relationships, and driving. ADHD results in impairments in more major life activities than has been found to be the case with other outpatient disorders, such as anxiety or depression. ADHD has a significantly greater adverse effect on various long-term outcomes, as I've already mentioned, and these can be used as supporting evidence that the individual might have ADHD as an explanation for these impairments. ADHD may be more life-threatening than other disorders. For instance, ADHD predisposes to more accidental injuries, more accidents in the workplace, more driving difficulties, and also greater difficulties with substance use and abuse. It may also predispose to greater suicidality, which is either thoughts of suicide or attempts at suicide. Consequently, one may find that the history of the patient with ADHD may be checkered with such accidents or gestures. ADHD also arises largely from neurological and genetic factors. There is little, if any, involvement in social factors in causing the disorder. For more information on the etiologies of ADHD, take my course on this website on that subject. But relative to other disorders, such as anxiety and depression, ADHD shows a striking pattern of familial inheritance, and therefore the family history of psychiatric disorders can be very helpful in indicating whether adult ADHD may be possible in the patient. Also, bear in mind that adults with ADHD are more responsive to medications designed to treat their disorder than are other adults who may have other disorders and are taking other medications. ADHD in adults is a highly treatable disorder. Treatability here refers to the degree of improvement in symptoms produced by the medications, which is greater for ADHD medications than for medications for other disorders. It also refers to the percentage of individuals likely to respond well to the medication. Between 70 and 80% or more of adults with ADHD are likely to respond to one of the medications for ADHD in the marketplace today. That is a very favorable success rate. Also, we find that ADHD medications are more likely to result in a normalization of symptoms, more than is the case with other medications used with other disorders. Research indicates that between 50 to 60% of people with ADHD are likely to place within the normal range in their symptoms following treatment with medication. Keep these in mind then when evaluating how adult ADHD may differ from other disorders. Some of this information may be very useful, in fact, for differential diagnosis. Another thing to keep in mind is that adult ADHD is a very costly disorder when it comes to educational malperformance or underachievement, or even leaving school before completing formal education, when it comes to the driving problems, the occupational problems, and so on. Adult ADHD is an incredibly expensive disorder and exacts a rather large cost upon society. One of the reasons an adult may be referred for evaluation of ADHD is because they are seeking accommodations under the Americans with Disabilities Act, either in educational settings or in workplace settings. The testing agencies or other agencies that may grant such accommodations frequently require that documentation be thorough and specific if one is claiming that adult ADHD is present, so that the reports of the clinical evaluation, in order to meet ADA requirements, should contain the following pieces of information. First of all, ensure that the report indicates the credentials of the clinician and why it is that they are expert in evaluating ADHD. Now, for clinical psychologists and psychiatrists, their background and training is sufficient for doing so. But for other individuals, such as primary care physicians or social workers, there may need to be additional documentation provided along with the patient's report indicating just how it is that this clinician considers themselves to be an expert in the evaluation of an adult with ADHD. The individual clinician needs to put in the report that they have employed formal DSM criteria for ADHD in obtaining their diagnosis, and they need to indicate that they employed the criteria twice, once in reviewing current functioning of the patient, and then again reviewing the DSM criteria for the patient's recall of their childhood functioning. The report also needs to indicate what attempts were made to corroborate these reports through another person who knows the patient well. Also, the report needs to indicate the history of onset of the symptoms, and that the onset of symptoms that produced impairment occurred sometime before 12 to 16 years of age. The report also needs to indicate that the patient shows a chronic course of their symptoms with no periods of symptom remission. And the report should indicate that impairment in one or more major life activities developed prior to 18 years of age. Again, these reports of impairment also need to be corroborated through someone else who knows the patient well, and that too needs to be indicated in the report. The report also needs to indicate that there is impairment in current functioning, not just a history of impairment previously in major life activities. And as I've already indicated, the report needs to indicate that impairment is a significant deficiency relative to the norm or the average person standard, not just relative to the patient's IQ or to other people who may be in college with this patient. The report needs to show that it has ruled out other disorders and other explanations for the patient's complaints. For instance, if the patient is complaining that they have difficulty taking timed examinations, but there is no other indication of impairment in any other major life activities, then the clinician may need to indicate why test anxiety is not a better explanation for the person's difficulties with structured timed examinations. One also needs to indicate in the report just what methods were used to rule out the possibility of malingering or feigning of symptoms in order to gain these accommodations. And then indicate in the report any prior treatments the patient has received for adult ADHD or any other accommodations they may have received in various settings, such as in earlier educational settings or in workplace settings. If the patient is claiming that they have ADHD but has never received any prior treatments or any prior accommodations, then the clinician is going to have to explain how the individual has gotten this far in life without receiving any treatment for what is a relatively serious outpatient disorder. Clinicians also need to explain why these treatments, if any are currently being received, are not sufficient in dealing with the disorder, and why additional accommodations are going to be needed in the environment that is the subject of this evaluation, such as educational settings or workplace settings. Why aren't prior treatments enough to address the problem? And then in recommending specific accommodations, clinicians are going to have to justify their specific recommendations and not simply rattle off a list of recommendations without explaining why they are necessary for this particular patient. For instance, recommending extra time on standardized exams without explaining why this would be beneficial to this patient is likely to be rejected. Now, I mentioned previously that malingering is likely to occur when benefits are likely to ensue immediately from receiving the diagnosis, particularly where requests for accommodations under the ADA are being made, or as I've said, where financial settlements may be at stake, where insurance claims are being made, or where individuals are undergoing criminal trial or sentencing. What means might one use for detecting malingering in these circumstances? Keep in mind that malingering is most likely to occur when there is an immediate benefit, as I've already indicated. This is especially so in college students requesting evaluations for ADHD in order to get accommodations in the college setting. Understand that there is no single foolproof means for documenting that a patient may be malingering. One therefore needs to collect multiple sources of information. My suggestion is that you collect a variety of such sources through various methods, and that you triangulate these sources of information against each other, making multiple three-way comparisons. I call this the GPS approach to detecting malingering. Like a global positioning system device, such as a GPS used in your car, one needs to have three different sources of information in order to triangulate and determine the person's position in geographic space. The same is true with determining the possible accuracy of a patient's reports. So the patient's reports can be triangulated against their own history and its credibility, against the reports of other individuals about the patient's current and past functioning, against rating scales completed by the patient and scored up against population norms, against rating scales obtained by collaterals who know the patient well. Triangulation can also be made against archival records and the paper trail of impairment, as I've already mentioned it, against clinical observations and impressions made by the expert clinician doing the evaluation. Also, the results of the medical exam may be pertinent. Psychological testing, particularly tests that may be symptom validity measures, are also another source of information that can be used in triangulating the patient's reports and other sources here against these tests. And then finally, any records from prior evaluations of the patient may also be pertinent to making this determination. It is very difficult for a patient to fake all of these sources of information in support of a diagnosis of adult ADHD, but it is very possible for one or several of them to be biased by malingering. Finally, as I've mentioned, one might wish to employ symptom validity tests, such as the word memory test, the word reading test, or the medical symptom validity test. But bear in mind, most of these are assessments of memory or of academic achievement, specifically reading. These may or may not be useful tests for detecting the possibility of malingering for adult ADHD. Now let's turn from the subject of evaluating adult ADHD to the treatments that might be recommended for adults following the diagnosis. The very first intervention I believe that is essential is educating the patient about ADHD, about its causes, its course, its nature as a disorder of self-regulation and executive functioning, and the likely treatments that are available in order to address the disorder. It is my opinion that education is one of the most useful interventions because it helps the patient to reframe their problems under the category or under the diagnosis of a neurogenetic disability, so that ADHD is like diabetes. It is a chronic disorder that often results in significant secondary harms and needs to be managed on a daily basis. I think it is very important that patients understand this perspective. Failure to do so is likely to result in patients shopping for magic cures or silver bullets on the internet that might be used to eliminate their ADHD, where no such treatments exist. In addition to educating the patient about their disorder, I strongly recommend that patients be enrolled in one of the 3 cognitive behavior therapy programs that have been found to be useful in improving the symptoms of ADHD and improving executive deficits in functioning in daily life in adults with ADHD. There are 3 different versions of CBT for adult ADHD. These focus on improving executive functioning, such as on strategies for self-restraint and inhibition, for time management, for personal organization and problem-solving, for emotional self-regulation, as well as for self-motivation. These programs have been developed at Harvard Medical School by Steve Safran and colleagues, who has a clinical manual published on the subject, available through major publishing companies. There is also a similar program developed by Russ Ramsey and Anthony Rothstein at the University of Pennsylvania. This program has also been published as a clinical manual with descriptions of session-by-session treatment recommendations. And finally, in March of 2011, Mary Salanto and her colleagues at the Mount Sinai Medical Center in New York City have published their version of a CBT program for executive training of adults with ADHD. So I recommend that you familiarize yourself with one or more of these manuals and consider enrolling patients in either individual or group training using this very structured CBT program. Research indicates that these forms of CBT can in fact improve ADHD symptoms and executive deficits beyond the improvements obtained by medication alone. I also recommend that you consider medication for your adult ADHD patients. My feeling is that more than 80% of adults with ADHD are going to need medication in order to address the seriousness of their ADHD. Research shows that these are the most effective treatments available relative to all other psychosocial treatments. Now, as I've mentioned in my course on ADHD medications on this website, there are several classes of medications available for managing ADHD. The stimulants are certainly the oldest and the best investigated approaches to ADHD management. Here again, there are various delivery systems that clinicians can use. The immediate release pills, the sustained release pellets, such as in Focalin XR or in Adderall XR, the osmotic pump system, which is evident in the Concerta delivery system for methylphenidate, and the skin patch system for methylphenidate, which is Daytrana. Also, more recently, a formulation of amphetamine has been put on the market that has a lower abuse potential than the immediate release forms of amphetamine. This is known as a prodrug, and it is Vyvanse. Now, there are 2 non-stimulants that have been FDA approved for the treatment of ADHD. They are atomoxetine under the brand name of Strattera, and guanfacine XR, which is an antihypertensive drug marketed under the brand name of Intuniv. Now, some clinicians like to use antidepressants or antihypertensives with adults with ADHD, but these are not FDA approved for this purpose. Certainly there is little evidence that SSRIs, or that form of antidepressant, is useful for adult ADHD, but tricyclic antidepressants have been tested in the past for adults with ADHD and have been found to be of some use. Nevertheless, the stimulant medications and the norepinephrine reuptake inhibitor atomoxetine would likely be tried first before proceeding to a tricyclic because of the greater safety profile for these other medications in comparison to the old first-line tricyclic antidepressants. The same is certainly true for employing antihypertensive medications. The above medication should be tried first before trying other such antihypertensives such as clonidine. And certainly there is no indication that atypical antipsychotics or mood stabilizers are useful for the management of ADHD, even though they may be useful for the management of certain comorbid disorders, such as bipolar disorder. I strongly recommend that you employ the long-acting versions of these medications whenever possible in order to be able to cover the greater waking day of adults into the evening hours and to help address their greater responsibilities relative to children with ADHD. If necessary, you can supplement these long-acting or extended-release delivery systems by adding in immediate-release versions of these medications at the end of the day if necessary. In many instances, combined or polypharmacy is likely to be necessary, and that is because over 80% of adults with ADHD are likely to have a second disorder, and more than 50% are likely to have a third disorder, and so comorbidity with other disorders is quite common. Typically, other medications may be needed to address these other disorders. The most common comorbid disorders are typically anxiety disorders, depression, and other externalizing disorders, such as oppositional disorder, conduct disorder, and antisocial personality disorder. Besides medications, clinicians should consider recommending vocational assessment or career counseling for adults with ADHD who are having particular problems in a specific employment setting. I find this especially valuable for young adults who have not yet started their careers or who have begun their careers but are at an early stage and have the flexibility to perhaps shift to a different type of career or at least to a different workplace setting within that career that may be more friendly or better suited to their ADHD symptoms. So I think it's useful for clinicians to consider the possibility of other jobs for ADHD individuals that might better suit their ADHD symptoms, their particular aptitudes and interests, and try to match these with particular types of employment and particular employment settings. Adults with ADHD often report that they appear to do better in jobs such as jobs in physical education, jobs that involve lots of movement such as door-to-door sales, jobs that involve interacting with other people frequently, such as in retail sales, jobs that involve performing arts, such as acting, or music, or stand-up comedy. The military is another area in which adults with ADHD have reported having some success. Whatever the type of employment, I think it may be useful, especially for young adults, to undergo vocational assessment and career counseling. In addition, there will be times where professionals may be asked to consult to employers about possible accommodations in the workplace for an adult with ADHD. Adults with ADHD are protected in the workplace under the ADA and do have the right to accommodations, but the key word here is to reasonable accommodations. Also, the adult has to document their diagnosis of ADHD properly and show that the treatments that they are receiving are insufficient to help them address their ADHD in that workplace environment before they are likely to be granted any reasonable accommodations. My colleagues and I have also found that sometimes declaring ADHD to an employer can backfire and lead to the individual being scrutinized more closely, having their failures at work documented, and then being fired from that employment because of their documented deficiencies. So I do not encourage all adults with ADHD to go running down the hallways of their workplace screaming about the gift of their ADHD or demanding that accommodations be made. This is a very sensitive issue, and I think it needs to be addressed in each individual case, considering the type of employer and the likely compassion of the employer to provide such accommodations. Adults with ADHD who are married or who are cohabiting with other individuals may also be good candidates for marital or family counseling. If you wish, I recommend that you have patients read Gina Perra's book, Is It You, Me, or Adult ADHD, which is an excellent paperback book on the impact of ADHD on cohabiting or marital relationships, and is filled with lots of recommendations for how to address these difficulties in the relationship. Structured marital therapy may be necessary with the ADHD individual and with their partner. We have often used approaches such as problem-solving and communication training methods in order to help address these difficulties. I also recommend that some counseling be done with the couple with regard to dividing up household responsibilities so that the non-ADHD partner assumes the time-sensitive responsibilities such as paying bills, getting children to school or to their doctor's appointments on time, and so on. Instead, the ADHD individual can assume the non-time-sensitive responsibilities, such as various chores or other household responsibilities, such as bathing children or dressing them for school, or the yard work that may have to be done around the home, and so on. So a division of labor with an eye toward which responsibilities are time-sensitive and which aren't may be a useful recommendation for adults with ADHD and their partners. As I've already mentioned, many adults with ADHD have comorbid disorders, and various psychosocial interventions or other pharmacological interventions may be necessary to address these comorbidities. In addition, adults with ADHD, as indicated in Part 2 of this course on ADHD in adults that dealt with impairment, adults with ADHD are likely to have substance abuse difficulties. They use alcohol, tobacco, and marijuana much more than other individuals. And if they have a history of conduct disorder, are highly likely to qualify for a substance dependence or abuse disorder. Therefore, these adults are good candidates for referral to substance abuse treatment programs or smoking cessation programs. Besides these more general treatment approaches, there are a variety of very specific strategies that can be recommended to adults with ADHD to help them cope in workplace or educational settings. These are two of the most impaired domains found in adults with ADHD. So let me go through a variety of such recommendations for you. First of all, we recommend that adults try to make themselves publicly accountable to others across the day for the particular goals they have set for the day, or for particular self-change programs in which they may be engaging, such as exercise, weight loss, managing their cholesterol or their diet, and so on. Finding someone else, such as a friend, partner, neighbor, or someone at work, who is willing to meet with you for even 15 minutes 5 minutes 3 times a day is likely to increase the success of patients with ADHD in meeting their goals or in their self-change programs. In addition, we recommend that patients find a mentor, as we call them, at work, or if they're in a college or educational setting in that environment, who can help to coach them in that setting. Here again, you're simply asking this person to provide you with 15 minutes a day. This should be broken up into at least 3 5-minute visits in the morning, at midday, and late in the day. During these brief visits, the patient is to report to their mentor what their goals were and what progress they have made toward meeting those goals. Now, if one is going to ask another adult to perform this function in these settings, then I strongly recommend that adults provide periodic rewards to these mentors for serving in this capacity, whether it is buying them lunch once or twice a week, or getting gift certificates for them, or so on. One needs to reinforce these mentors for serving in this role, or they will likely be burned out relatively quickly from providing this additional supervision. Now, besides public accountability, we also think that people with ADHD should locate the ADHD specialists on college campuses, typically in the Disability Services Program, and rely on them frequently to also help them with public accountability. These experts can provide counseling, cognitive behavioral therapy, executive function training, or just provide the mentoring services mentioned above in order to help the young adult in the college environment to be more successful. Now, as I've mentioned, adults with ADHD are likely to be using nicotine, caffeine, alcohol, and others substances in order to try to cope with their ADHD symptoms. Both caffeine and nicotine are stimulants, and certainly nicotine does provide some positive benefit for management of ADHD symptoms, but obviously the patient is self-medicating with a highly addictive drug. So we encourage patients who are overusing these substances to try to voluntarily cut down on them, and if necessary, take advantage of smoking cessation programs or other substance use programs in order to try to curtail the overdependence on these medications. These programs can be provided, as I've mentioned, through alcohol treatment programs, smoking cessation programs, or programs for more hard drug abuse, such as inpatient programs for detoxification. Now, we also suggest that if the patient is not enrolling in one of the CBT programs already mentioned, that they consider getting formal advice from a time management expert or an organizational specialist if they happen to be available in the geographic region. Check the yellow pages for such experts. You can work closely with them to educate them about adult ADHD so that they can properly advise your patients on changes to the home or the workplace in order to facilitate better time management and personal organization. There is also available in the United States the coaching network. You can simply Google this term and you will find various websites and a variety of coaches around the United States who have had training in adult ADHD and are willing to work for a fee as coaches. Coaches work just like mentors do above in providing public accountability, but they also have additional expertise in ADHD so that they can counsel patients about their disorder and also recommend other treatments that may be needed and available within that particular geographic region. Coaching has been found to be a useful supplement to medication in helping ADHD individuals with their time management and personal organization. Another recommendation for work or for school is for patients to buy daily assignment calendars such as the Week at a Glance calendar, or simply to purchase blank journals in which they are going to write down everything they agree to do, or everything that they've been told to do by others, or every promise that they've made, or specific information that is very important for them to remember. And then they should refer to these calendars or journals frequently throughout their workday. We believe that these devices, which are low-tech paper and pencil devices, are even more useful than our more high-tech technology devices such as digital recorders or personal computers for serving this purpose. These calendars and journals are ways of compensating for the working memory deficits that adults with ADHD are likely to find problematic. Now, there are technology and software devices that individual adults with ADHD might find useful. I've already mentioned a few of these, such as digital recorders or the Outlook program for scheduling of appointments and work, but also one can check out the Watchminder, which is a wristwatch that can be programmed weekly and will provide reminders for upcoming deadlines prior to the arrival of the deadline. You can learn more about the Watchminder at the website addwarehouse.com. You can also Google the term Watchminder to learn more about the device. Now, adults with ADHD often complain of having difficulties with their handwriting or with the legibility of their penmanship, and so we often encourage them to learn word processing and to use computer word processing programs or dictation into dictation recording devices as means of meeting their commitments or obligations for written reports, projects, or class assignments in the case of college students. Frequently, adults with ADHD have trouble with reading, viewing, and listening comprehension due to their working memory impairments. One way to compensate for these problems with comprehension is to tape record important lectures in educational settings or important meetings in workplace settings so that one can review these recordings later in order to make sure that one has gotten the most information out of the meeting. Another means of doing so is a device called the Smart Pen, which you can read more about at the website livescribe.com, as you see on this slide. This is a pen that also has a digital recording device in the upper part of the pen. And by tapping the pen on a particular recording or on a particular sheet for recording notes, one can start and stop the digital recording device, which can serve to record these lectures or meetings. I encourage you to learn more about the Smart Pen at this website. We also encourage students in educational settings, such as on college campuses, to get any extracurricular materials or any after-class assistance that faculty members are willing to provide them, even if it's simply going to the faculty member's class and staying there after class in order to do their assignment while the faculty member may be grading papers. This kind of structure can be very useful in seeing to it that the assignments are done on a more timely basis, and having the faculty member available also helps should the patient encounter questions in completing their homework. It's also advisable for adults in the workplace or on college campuses to work or study with other individuals who are known to be highly organized and good time managers, or to work or study in small groups. This is yet another means of using other people to help structure the adult with ADHD in helping them to stay on task, persist in their work, and get their goals completed in a timely fashion. Now, additional suggestions for the workplace or college campus are as follows. Make sure that you schedule more difficult classes, more boring meetings, or more difficult work assignments in the late morning to early afternoon hours. Research has suggested that adults with ADHD have a slight delay in their diurnal rhythm. That is to say that they report their peak hours of alertness and attention to be late morning to afternoon rather than to early morning hours as are reported by other adults. So learning your peak hours of the day as to when your attention span is at its maximum, and then scheduling more difficult work or classes into these hours can be a very useful accommodation for the attention deficits that ADHD adults experience. We also suggest that adults with ADHD try alternating difficult or boring work or educational assignments with more interesting and fun assignments in an alternating sequence so that they are not demanding themselves to pay attention to difficult or boring work for long or protracted periods of time. Now, it is often recommended that adults in educational settings get extra time on standardized time tests, such as on the SATs, on the GREs, on the law boards, on the USMLE medical exams, and so on. There is no research to show that extra time is beneficial for adults with ADHD. Indeed, some surveys of adults with ADHD indicate that they have not found this to be particularly useful. And certainly there is no research to back up the beneficial effects of extra time. Our research and our surveys with adults with ADHD suggest two other strategies that may be more beneficial in helping these adults to take timed examinations. First of all, take the exam in a relatively distraction-free or individual test setting. Second, use a strategy known as time off the clock, which is a form of self-pacing for the exam with frequent breaks. Time off the clock goes something as follows. When an individual has to take a timed exam, they are given a stopwatch. When the exam begins, they start the watch. However, whenever they like, they can stop the watch, stand up, take a break, get a drink of water, stretch, come back, and then start the exam again, at which point they start the stopwatch. They are to have no more face time with the exam on the stopwatch than other people are getting for performing the timed test, but they may interrupt the exam frequently as necessary and self-pace the exam by turning the stopwatch on and off. Now this certainly results in the adult needing extra time to take the exam, but notice that extra time is not the strategy. It is merely a byproduct of a better strategy of self-pacing the exam with frequent breaks. Now, research shows that physical exercise helps individuals with ADHD to cope with their symptoms and even to reduce their symptoms. And so we recommend that ADHD adults engage in routine, regular aerobic exercise. But it also may be a particular coping device to use just before going into examinations, boring classes, protracted meetings that are difficult to attend to, or doing long or difficult or boring work assignments. Going out for a run or engaging in other forms of physical exercise just before doing these other activities may boost the powers of attention and self-regulation of the adult with ADHD sufficient to get through these situations successfully. Another strategy for dealing with working memory problems is to use continuous note-taking when sitting in classes listening to lectures or when listening at discussions during meetings. The adult with ADHD should always have a pad of paper or journal next to them with a pencil and should always be taking notes, even if it's just short phrases, doodling hieroglyphics, or other means of taking shorthand in order to get information down on paper that they're going to need to remember after the class or the meeting. Now, we find that adults with ADHD often have difficulties with daydreaming or mind-wandering or becoming distractible during protracted work assignments, either in work or in the university environment. So, there are various tactile cueing devices on the market that can be used. You can set these devices to go off at any interval, and on that interval, or even on a random interval, the device vibrates. And the vibration is a self-cue to remind the patient to get back to work or to pay attention to what is going on around them. One such device is called the motivator, which you see here, which you can learn more about by Googling this term or by going to the addwarehouse.com, where you can find this and other such cueing devices. Now, in addition to these accommodations, other suggestions we have for adults with ADHD is the SQ4R system for improving their working memory and reading comprehension. SQ4R is a strategy that has been around for decades. It's often used in school classes to help boost reading comprehension, but it can be used by adults with ADHD at any time. They have to read extensive material and remember it. SQ4R is an acronym for the strategies or steps that the adult is to employ when reading. First, survey the reading material that has to be read. Second, draft up a series of questions that must be answered after the material has been read. Then, read one paragraph. Recite out loud the major key pieces of information in that paragraph. Now write them down. Now review your notes, and if necessary, read your notes subvocally back to yourself. Obviously, this refers to the 4 R's: read, recite, write, review. Then go on to the next paragraph. And do this paragraph by paragraph as you proceed through the reading material. Now, this will certainly take longer to read the material than other people require, but it is a lot more efficient than what adults with ADHD do, which typically is to read a paragraph, get halfway down the page, forgotten what they've read, go back to the top of the page, and continue doing this 3, 4, or 5 times before they've completed the entire page. So SQ4R is certainly a more effective strategy for retaining information while reading than is the more typical approach of rereading the page multiple times. Now, we often suggest that if people have to study, that they study together. This is referred to as peer tutoring, and it can be done at work with a co-worker if new material has to be learned in the workplace with regard to one's job, or it can be done with other students in the college environment. In peer tutoring, one individual is the tutor, the other is the student, and then the two reverse roles as they go through the material, so that each gets an opportunity to teach while the other is the student, and vice versa. This is a very useful means of learning new material, and by using a peer, it helps to structure the ADHD adult to stay on task. You can also do this by working as a team with a number of other individuals in order to accomplish projects. We also suggest that college students find another student and swap phone, fax, or cell phone numbers with these individuals so that if they find themselves missing an assignment or they've lost some material, they can contact these other students in their classroom immediately to try to get the lost material. As I've recommended, I think that students with ADHD should take advantage of any after-class or after-work help sessions that may be provided in these two environments. And then schedule review meetings with faculty on the college campus or with supervisors in the work environment to review your progress toward your goals. We recommend that this be done every 3 to 6 weeks so that the individual is not drifting or falling between the cracks and experiencing more severe adverse consequences if their difficulties in these environments go on too long. Now, as I've suggested, I think regular exercise programs are very useful for adults with ADHD, and I strongly encourage that they do so, not just for improving their attention span at work or in college, but in order to address the health problems that I mentioned in Part 2 of this course on ADHD adults. Adults with ADHD are more prone toward obesity. They are also more prone to coronary heart disease. And they are more prone to stress in all walks of life. And so exercise may be one means of helping to address these other health problems, in addition to helping them to concentrate better at work. One issue that comes up from time to time in counseling adults with ADHD who happen to be parents is about the risks that ADHD poses for their parenting ability. There have now been a number of studies on the impact of adult ADHD on child raising, and the impact is not a positive one. Adults with ADHD who are parents are more likely to have children with ADHD because of the genetic nature of the disorder. Indeed, 40 to 54% of the offspring of adults with ADHD are likely to have that same disorder. This can pose problems in the family, of course, increasing family conflicts. We also find that parental ADHD increases the risk that an offspring may develop oppositional disorder, even if the offspring does not have ADHD. Parental ADHD is often associated with being young as a parent, as I indicated in my other lectures, particularly Part 2 of this 3-part course on adult ADHD. Adults with ADHD are likely to have their children younger than is the general population, and indeed they may well have a child by the time they are 19 years of age. 40% of the individuals that we have followed with ADHD from childhood to adulthood had a child before they were 20 years of age. So expect to find that adults with ADHD, if they have children, probably had them at a much younger age than did the general population. Young parenthood poses problems in its own right, as I'm sure you know. We also find that adults with ADHD who are parents are more likely to be unwed parents, are more likely to be in marriages that are unsatisfactory, or marriages that report higher levels of distress. And so this needs to be kept in mind when evaluating ADHD adults who are parents. They also report being more distressed in their role as a parent, and are more likely to have unplanned or unwanted pregnancies, which pose their own distress to the family situation. ADHD in a parent has been shown to reduce the likelihood that they will monitor their children's activities, and parental monitoring is a risk factor for children experiencing accidental injuries. So this may also need to be addressed in the parent with ADHD, and that is finding formal ways to help remind them to check on their children's activities frequently. ADHD in a parent has also been found to result in inconsistent use of discipline and in use of harsh discipline more than is found in other parents. We also find that parental ADHD sometimes leads to decreased involvement in children's leisure time activities. and to lower rates of social reinforcement of children's prosocial behavior. So one might need to work with an adult with ADHD who's a parent on improving these particular parenting skills. Here are some references you might wish to read with regard to parental ADHD and its impact on child rearing. Now, what suggestions can you make to a parent if they have ADHD with regard to dealing with their children and their family responsibilities? First, consider going on medication and making sure that your medication covers the time that you are engaged in parental responsibilities. Research shows that ADHD medications not only improve symptoms, but also improve parenting behavior. Consider undergoing a more formal behavioral parent training program at a local psychology or psychiatry clinic. Now, if the parent has ADHD, research shows that the parent should be treated for their ADHD before enrolling in these programs, or the parent's ADHD is likely to interfere with or lead to outright failure in the parent training program. Have the non-ADHD parent handle schoolwork and other time-sensitive issues with regard to children, so that the ADHD parent can assume other roles with the child, such as dressing and bathing of the child, playing with the child, or babysitting the child, in order to make up for the responsibilities that the other parent is assuming with that child. Each parent can also alternate nights for being responsible for child care. So let's say on every other night, the non-ADHD parent is responsible for caring for the children, seeing that homework is done, and getting the children ready for bed. And then on alternating nights, the adult with ADHD can assume these responsibilities. This ensures that neither parent is carrying the burden of child care or child rearing to excess. Also, let the non-ADHD parent handle time-sensitive issues with children or with family responsibilities, such as getting children to school on time, or getting children to their doctor's appointments on time, or paying bills on time. The non-ADHD parent is more likely to follow through on these time-sensitive issues than is the ADHD parent, who can make up for this division of labor by taking on other non-time-sensitive responsibilities. We also suggest that parents with ADHD find a means to put themselves in time out when they feel that they are becoming overwhelmed by their child, excessively stressed, or excessively emotional. Go to their bedroom, close the door, and take their own time out in a quiet location until they have regained emotional control before dealing with the child, and particularly with problematic child behavior. We also suggest that if the adult with ADHD plans on disciplining the child in some major way, that they first always consult their partner or the other parent before doing so, in order that there may be a reasonable discussion around more rational forms of punishment, so as not to engage in impulsive and excessive use of harsh discipline. I also believe that the non-ADHD adult should be responsible for driving the children to their various activities whenever possible, unless the adult with ADHD is taking medication. ADHD poses serious risks in the area of driving, and one would not want one's children exposed to those risks unnecessarily. Again, one can use external cueing devices, such as the timers with vibrators built into them, such as the motivator mentioned on the previous slides, and other cueing devices, such as cooking timers or oven timers, in order to remind the parent to monitor their children's activities. So set these timers to go off at frequent intervals, and then when the timer sounds, go find your children and find out what they're doing and where they are, in order to make up for the problems that ADHD poses for monitoring of children's activity. One final word has to do with advising families who may be dealing with an adult with ADHD that does not wish to cooperate with treatment. I have personally had this happen in my own family, and my recommendations are based here both on my experiences as well as on the families of other uncooperative adults that we have advised. we advise these families to cease moral interpretation of the patient's behavior and view ADHD instead as the neurogenetic disability that it is. ADHD is a frontal lobe syndrome, and certainly no one would interpret the deficits associated with frontal lobe disorders from a moral perspective, or that simply of willful disobedience. So, regard the patient as mentally ill, and hopefully this will bring about a certain amount of compassion and willingness to make accommodations and exceptions for the ADHD adult. We also suggest that loved ones serve in the capacity of being a safety net for the ADHD adult, providing financial assistance where necessary, or other assistance such as health maintenance, medical care, and dental care, so that the ADHD adult does not fall through the cracks and develop significant medical or dental problems, or wind up in serious financial difficulties. This is not in order to enable misconduct. Instead, what we are recommending is that family members try to keep the ADHD adult from becoming homeless or worse. We are not suggesting that you give cash to the ADHD adult whenever they ask for it, but provide structured financial assistance as needed to these adults for particular critical services. Also, we think that the family members should be ready to support the ADHD adult whenever they suggest that they are willing to engage in constructive, life-improving activities, such as getting on medication, getting further education, getting job training or retraining, locating more appropriate forms of employment, enrolling in a substance detox program or smoking cessation program, or simply enrolling in cognitive behavioral training programs for ADHD. Whenever the adult with ADHD makes a suggestion that they are willing to engage in these services, family members should be ready to act quickly while the patient's motivation is high in order to get them into these programs. Finally, we recommend that family members always stay involved in the lives of the adult with ADHD, even if they are non-compliant with treatment. Using ultimatums, threatening to disengage from the patient, or becoming estranged from the patient are unlikely to be of any benefit to the adult with ADHD. I recommend that one reads Stephen Covey's book, The 7 Habits of Highly Effective People, or Highly Effective Families, in which you will read about what Covey calls the emotional bank account. An emotional bank account is simply a metaphor for one's relationship with one's family members, and one needs to make deposits into that bank account, deposits that involve goodwill, support, encouragement, and positive feedback, because from time to time one is going to need to make a withdrawal from that bank account in giving advice to patients, or in being critical of what patients are doing, or in giving I believe, recommendations for getting treatment to these individuals. And this advice is unlikely to go heeded unless there is ample investment in this relationship or emotional bank account. So stay involved and supportive of the ADHD adult no matter what. Otherwise, you will find yourself not being of particular influence in helping these adults deal with their disorder and their impairments. I hope you've learned a great deal from this course on adults with ADHD. In this part 3 of my course, you've learned about the evaluation of adult ADHD, and that this evaluation relies on multiple methods and multiple sources of information, including unstructured and structured interviews, narrowband and broadband rating scales, using collateral reports of current functioning and of childhood functioning, collecting psychological testing information, particularly about intelligence and academic achievement, using symptom validity measures where appropriate to detect potential malingering, relying on archival records of impairment that can support the patient's reports of their impairment in various major domains of life activities, using rating scales of impairment such as my normed functional impairment scale, and of course, collecting clinical observations and impressions about the patient. All of these sources of information go into conducting a thorough evaluation of an adult for ADHD. I also hope that you've learned that the diagnosis of ADHD should be based on modified DSM-4 criteria or on the new adult ADHD symptom list that I reported in Part 1 of this course, as well as using a more broadened age of onset requirement of onset prior to 12 to 16 years of age. All of this is to say that DSM-4, as it's written, is inappropriate for the diagnosis of adult ADHD and requires some modification in order to retain its sensitivity to the diagnosis of ADHD in adults. I also hope that you've learned that the management of adult ADHD relies on a treatment package of services, including an appropriate diagnosis and thorough evaluation, education of the patient and family members about ADHD, reliance on ADHD medications or other medications for the management of comorbidity, using behavior modification and other accommodations in the workplace, educational, and family environments, and so on, in order to put together the most effective package for addressing ADHD and the impairments associated with it. ADHD in adults is a highly treatable disorder. There are more methods for treating ADHD than for many other psychiatric disorders, and these methods, such as ADHD medications, result in more improvement to a greater degree for more people and result in greater rates of normalization of symptoms than is the case for many other psychiatric disorders. So there is reason for much hope about the management of ADHD in adulthood. Thank you for taking this course. I hope that you will take the other 2 courses on adult ADHD on this website. I also invite you to take other courses that I have prepared on ADHD at this website. In addition, I invite you to visit my publisher's website, guilford.com, to learn more about products I have related to ADHD. For instance, you can learn about my 3 new rating scales for conducting evaluations of adults, particularly adults with ADHD, such as the Barkley ADHD Rating Scale 4, the Deficits in Executive Functioning Scale, or the Functional Impairment Scale, for evaluating psychosocial impairment across 15 different domains. I also have textbooks on ADHD, as well as trade books for adults with ADHD, as you see here, as well as for parents of ADHD children. I invite you to have a look at these and other products at my publisher or at other major booksellers. Thank you very much for taking this course. Goodbye.